Hi, I wanted to give a brief update on the X-ray TechNote. So far, most sites are using the TechNote. There are still some places that have not been, and I've asked some of the managers to help make sure that it is being used. And because it's not being implemented at many sites, and because there are still some issues with filling out things appropriately, we haven't pushed very hard for radiologist adoption. So you've probably not seen a lot of radiologists using the report yet, and part of the reason for that is we're still waiting to make sure that technologists understand what they're doing in terms of what's expected of them to fill out the note and to use it regularly, so that radiologists can use it effectively. When it's not filled in and we use a template that relies on this note, that causes a serious slowdown and problem. So towards that end, I wanted to talk about a couple of things. First of all, to re-emphasize this issue of bilateral studies, which is still the biggest problem that I see when I look at studies. Just to remember, so you know, CPT codes are how images are billed, and they rely on this term views, and people get confused about what views mean. And basically, views mean different kinds of projections. So an AP view, a lateral view, that's different than a repeat of the same views, like two views of a lateral knee that one was obtained because the person was a little rotated and then you wanted to get a better image the second time. So all these codes are called CPT codes, and that's how our billing people get reimbursed for our images, and that includes our whole institute and our whole institution. So all of the billing that we do is dependent on this, and that pool of reimbursement, of course, is for all of us, and so we want to do a good job of getting it right. Now, this is the kind of situation that I continue to see issues with. I think I've mentioned it a few times, and I want to re-emphasize it one more time, that in a bilateral study, we have to list in views the number of views of each side that was obtained if it's a bilateral study. So in a bilateral knee, there are 1, 2, 3, 4 views of this knee, and 1, 2, 3, 4 views of that knee. So this, in under views, you write 4 each. You have to use the word each. If you just put the word 4, then someone might use there are different CPT codes that aren't listed here, but they might use a knee 2 view to bill, which would be underbilling this case. Okay, it's 4 views of each side, so they're going to get bilateral knee billing for 4 views of each side, and then the total number of images is the same as the total number of plates or cassettes or thumbnails that you get. 1, 2, 3, 4, 5. Okay. If you have questions about views, you can ask me. I'm happy to try to help, but I always just go to Elizabeth Colai, who has been really helpful in trying to sort out what the appropriate number is. And frankly, there is still some ambiguity about certain things, but she's a great resource, and I've asked her. She said it's okay for people to reach out to her to ask their questions about these things. Another thing has to do with contiguous parts. This came up. Someone came up to me and asked about ankle and foot. Usually an ankle and foot are read together. Now, that's not always the case. Sometimes I'll read the foot, and while I'm reading the foot, a different radiologist picks off the ankle. But this is an example where, if you wanted to, technologists could link the studies together, but you have to do it in a certain way. So, for instance, here's a foot, 3-view foot, 2-view ankle. You could just fill them out as separate orders, which is what I normally would ask you to do. Or if you wanted to, you could link these two. But when you do that, when you put in the views, you have to be careful. You should say something like this: foot 3, ankle 2. Don't put in 5, because that's confusing about what that applies to. That way, in our template, our macro, this will come in that the foot has 3 views, the ankle has 2 views, and that's clear to both the radiologist and also to our billing coding folks. Okay, and then for images, again, you have to separate it, but you only have to fill it out once. You only have to fill out one note if you want to link those things together. That's okay, but don't combine the total number of images, because it becomes ambiguous as to how to charge that. Now, there are other situations where you could do this if you want to do this. The hand and the wrist, the hip and the femur, T-spine and L-spine. You get the idea, but they have to be contiguous parts. They have to be on the same side of the body. So don't do a right ankle and a left foot, because that will come out strangely. You won't be able to pick one laterality for that, if that makes sense. And in each situation, you would say the number of views for each part. If you wanted to, you could fill that out in one note. History. History has been very helpful. I've been very appreciative of what I've seen. Mostly good job. Occasionally I'm seeing people just repeating what is in already naturally imported by the order. And I just want to give you a very brief idea of what's helpful. It's not just helpful for us clinically, it's also helpful for billing. ICD-10 now relies on certain words, especially if you have a normal report. Billing can be related to the kinds of symptoms and signs that the patient has had. So really any additional information is helpful. No one expects technologists to provide a medical history like a physician. It's nothing like that. But we're looking for the kind of symptoms that they're having. Sometimes it is pain, but if you just write pain alone, that's not very helpful. Was it pain because of an injury, or was it pain because they've had chronic pain for years and years, or is it pain because they just had surgery? All those things are potentially useful kinds of things, and it depends on the body part, right? So for a foot, maybe pain from an injury is a legitimate history. For the chest, it might be shortness of breath or chest pain, or in the abdomen, it might be nausea. Typically, so the symptom itself is very helpful. Giving an acuity, like whether it's acute or recent onset or chronic, meaning long-standing, those are useful bits of information for us to know what kinds of diagnoses go with that kind of history. And then location, of course, is very important, especially in the musculoskeletal system. And I've seen a couple of cases where people have, as I've asked before, marked area of pain, either with an arrow on the film or a digital arrow placing the site of the symptoms, has been extremely helpful. And if I can, I'll try to put a link up to an example of that. Anyway, I want to thank you again for your patience, your hard work. Please hang in there and keep trying to do this. Please ask any questions, but do give it an effort. And remember, I linked to Elizabeth Colai. She's a very helpful resource for some of these questions. And we'll keep going from here. Thank you.